Brachial plexus paralysis is a rare but significant complication that can occur after thoracotomy through a median sternotomy. This surgical approach, often used for heart and aortic procedures, involves splitting the sternum to access the thoracic cavity. While the global incidence of brachial plexus injury after this procedure ranges from 0.5% to 38%, most cases are expected to improve within 6 months. However, some patients experience persistent symptoms which can greatly affect their quality of life. The paralysis is typically classified into two types: lower radiculopathy, which mainly causes sensory impairment and usually has a good prognosis, and upper or middle radiculopathy, which is less common but often leads to more severe movement disorders and a poorer prognosis. Understanding these distinctions is crucial for clinicians and patients alike, as it shapes expectations and guides postoperative care. Let's look at a recent case that highlights the challenges of brachial plexus paralysis in petite patients. A 53-year-old woman, standing 152 cm tall and weighing just 41 kg, underwent a descending thoracic aortic replacement via left thoracotomy. After surgery, she experienced movement disorder in her left fingers, numbness in her forearm, and persistent paresthesia. Despite receiving vitamin B12 and follow-up care, her motor function only gradually recovered over 8 months, and numbness in the median nerve region lingered for 18 months. This outcome is notable because, although lower radiculopathy typically has a good prognosis, the nerve compression in smaller patients can be more severe, leading to prolonged or incomplete recovery. This case underscores the importance of careful surgical technique and heightened vigilance in petite individuals. How does brachial plexus paralysis occur more severely in some patients? The mechanism involves the lateral movement of the split sternum during surgery, which pushes the clavicle backward and rotates the first rib upward. This compresses the brachial plexus, especially in smaller patients where the anatomical space is tighter. Studies have shown that factors such as prolonged extracorporeal circulation, shoulder fixation, and additional procedures can increase the risk. Interestingly, women and those with smaller body frames appear more vulnerable, possibly due to greater relative movement of the sternum and ribs during surgery. This highlights the need for tailored surgical approaches and close monitoring in at-risk groups. Understanding these mechanisms helps clinicians anticipate complications and informs strategies to minimize nerve injury during thoracic surgeries. This case and supporting research remind us that brachial plexus paralysis after median sternotomy is a complex issue, especially in petite patients. Even when classified as lower radiculopathy, which usually has a favorable outlook, the prognosis can be unexpectedly poor due to more severe nerve compression. Clinicians should be particularly cautious with small patients, ensuring careful positioning and minimizing sternum movement during surgery. Early recognition and intervention are key, but as seen in this case, some symptoms may persist long-term despite best efforts. Ongoing research and accumulation of similar cases will help refine surgical techniques and improve outcomes. Ultimately, awareness and preventive strategies are essential to reduce the risk and impact of this challenging complication.